postgraduates. Today's topic will be on the pneumonia. So the definition: infection that inflames the air sacs, they are the alveoli, in one or the both the lungs. So in a single lung, unilateral pneumonia. In the both the lungs, it's a bilateral pneumonia. It can be caused by various pathogens like bacteria. So bacterial pneumonia, viral pneumonia, fungal pneumonia, sometimes and even a chemical irritants that can cause the pneumonia. When the alveoli become infected, they fill with the fluid or the pus. So the more the pus, more the sepsis and the septicemia, which can lead to the symptoms such as cough, fever, chills, and breathlessness. So the infection of the lung parenchyma, it's usually the bilateral pneumonia. So this is the alveolar filling with the fluid causing airspace disease. So it's considered as a consolidation with exudation. It has a reasonable morbidity and the mortality, especially in the elderly individuals and the people with the severe comorbidities like diabetes, hypertension, IHD, CKD, etc. 5 to 12% of all lower respiratory tract infections are due to the pneumonias. The incidence varies with the age, much higher in the very young and the elderly individuals. Community acquired pneumonia is usually spread by the droplet infection. Here see the lung parenchyma, the alveoli, air-filled sacs of the lung responsible for absorbing the oxygen from the atmosphere. So that's what the alveoli should do. But because of the inflammation and the fluids and the pus filling, so there will be the disturbance of this oxygen saturation in the lungs. They can be divided into the nosocomial pneumonias and the community acquired pneumonia. And community acquired pneumonia may be the bacterial, viral, fungal, parasitic, and eosinophilic pneumonia is also very common in our tropical countries. It could be lobar, bronchopneumonia, interstitial pneumonia, or sometimes the diffuse pneumonia. Nosocomial pneumonias are also very important for most of our physicians because we do the hospital acquired pneumonias, VAP, ventilator associated pneumonias, and healthcare associated pneumonias. So these are the right lobe, left lobe, the two things, and the right, the three lobes. So this is the lobar pneumonia when the entire lobe is involved. So this is the lobar pneumonia and the bronchopneumonia pictures. And the normal alveoli and alveoli filled with the fluid in the pus. So there will be the inflammation of the alveolar margins, cells. And if you see the epidemiology, it affects approximately 450 million people a year worldwide. So a lot of the people all over the world, the pneumonia will be there. It's a major cause of the death among all the age groups. 7% of the world's total death rate. And the fourth leading cause of the death in the world. The risk factors, they are the greatest in the children, less than the 5. And adults older than the 75 years of the age group. Even over India, even the age more than the 60 years, the elderly individuals also very commonly associated with the pneumonias. You need not wait up to the 75 years. Children in the developing countries are at a significantly higher risk due to malnutrition, overcrowding, and the lack of the proper housing. So these three are very common in our poor socioeconomic strata population. Other illnesses like malaria can also worsen the chances of developing the pneumonias. Not only the malaria, your dengue fevers or your enteric fever. So these, even though they are simple, there are some systematic in some cases. So the pneumonia is a very, very commonly associated co-complication with these common fevers. The most common bacterial causes are the Streptococcus pneumoniae and Haemophilus influenza. And you name any bacteria, so that can cause the pneumonia in our setups. Respiratory syncytial virus is the most common viral disease. 5 times more frequently in the developing world versus the developed countries. So India being the developing country, so definitely we have 5 times or more than the 5 times incidence of the pneumonias in our population. especially South Asia, have the highest prevalence of the pneumonia in the world, along with Africa. Pneumonia can be prevented through the vaccines. You have the influenza vaccine, you have the pneumococcal vaccine, a proper treatments with a good antibiotics or antiviral or antifungal, and healthy practices like using the mask, etc., hand washing, and reduces the indoor air pollution. And most cases can be treated with the oral antibiotics. And if they need the hospitalization, definitely you need parenteral antibiotics. If you see the pathophysiology, it's an acute inflammation of the lung parenchyma, primarily by the infectious agents. The pathophysiology of the pneumonia is a complex interplay between the invading pathogens and the host's immune response, leading to the inflammation and consolidation of the lung tissue. If you see the entry of the pathogens, they enter the lungs through the various routes. Aspiration, especially in the elderly individuals, the chronic alcoholics, or hospitalized patients, ICU patients, it's a very common aspiration pneumonia. That is inhalation of the secretions from the upper respiratory tract. Inhalation is the most important route, so the direct inhalation of the airborne pathogens. Hematogenous, the infection can also spread through the bloodstream from the other infected sites. So as I told you, it's an interplay between the invading pathogens and the host immune responses. So what about the defense mechanisms, immune responses? The lungs have the several defense mechanisms to prevent the infection. So the mucociliary clearance, alveolar macrophages, immunosuppression, CLD, and neurological defectors. Mucociliary clearance is a mechanism that traps and expels the pathogens and the debris. Even your cough, it's a protective. Alveolar macrophages, so these immune cells engulf the pathogens and trigger the inflammatory responses. Disruption of these defenses can lead to the pneumonia. The factors that compromise these defenses include immunosuppression, like HIV and AIDS. Last week we discussed about the HIV and the use of the immunosuppressive drugs. CLD is very common in the society because of the air pollution, more air pollution, because of the smoking, the COPD and the cystic fibrosis. Impaired cough reflex due to the smokers or other conditions can also lead to the defensive mechanisms weakening. Microbiological, it depends on the age of the patient and the clinical circumstances. The majority of the CAP was due to Streptococcus pneumoniae, Mycoplasma pneumoniae, that's atypical pneumonia, Chlamydia pneumoniae, they are also common in young individuals. H influenza should be considered in the elderly individuals, but is rarely reported in the young adults. In young children, the viral infections predominate, like respiratory syncytial virus or your influenza, etc. History of the travel may suggest the Legionella infections. Recent influenza may predispose to the staph aureus and the staph pneumonias. Now the term atypical pneumonia has recently been abandoned, but still we use the atypical pneumonia in for certain organisms. So these are the different phases of the pneumonia: congestive phase, rapid hepatization, gray hepatization, and finally the resolution. So the congestion occurs within the first 24 hours. There will be the vascular engorgement and presence of the intraalveolar fluid and the bacteria, leading to the heavy and red lungs. Red hepatization is the phase 2. A few days after the congestion, the lungs become red, foam, airless, resolving the liver tissue. So that is the reason we consider it as a hepatization, due to the accumulation of the erythrocytes, neutrophils, and the fibrin. And the third phase is the gray hepatization. It occurs about the 2 to 3 days after the red hepatization. The red blood cells break down and the lung tissue appears gray due to the fibrin purulent exudate and macrophage activity. And finally, resolution that begins around the 8th day. Enzymatic action liquefies the solid fibrinous content, restoring the lung aeration as the macrophages clear the debris. So these four phases are very important pathophysiological mechanisms in pneumonias. See here the concentrate on the left lung, lower lobe. So you can clearly indicate that. So that is the pneumonia of the lower lobe. See the normal alveoli and the abnormal or pneumonic alveoli. So in the pneumonic alveoli, there is inflammation of the alveolar wall. The alveolar wall thickening will be there, and there will be the accumulation of the fluid or the pus. So their fluid or the pus is filled with the air space. They contain a lot of bacteria and the blood cells like your macrophages, pneumocytes, etc. So aspiration of the gastric content of the bacteria enter the lung. This is aspiration pneumonia. So there will be the inflammatory response. The cavity extended to the bronchus. The abscess becomes encapsulated. So once the abscess becomes the encapsulated, the tissues necrotize, they increase the production of the sputum, and there will be the purulent sputum. So these are the three routes of inhalation route, aspiration, and hematogenous. Inhalation, when the organisms bypass the normal respiratory defense mechanisms, or when the patient inhales the aerobic gram-negative organisms that colonize the upper respiratory tract or the respiratory support equipment. Aspiration, already told you, the patient aspirates the colonized upper respiratory tract infection secretions, and hematogenous originate from a distant source and reach the lungs via the bloodstream, especially in the sepsis. So these are the different risk factors. Viral infections, they damage the cilia and produce the serous exudates. So the mucus clearance will be disturbed in viral infections. In age, elderly individuals, so the defect in the swallowing, reduced immunity, and more aspirations. In alcoholism, they depress the cough and epiglottis function. So again here, the aspiration pneumonias or hematogenous spread or inhalation spread is very common. Smoking, they damage the epithelial cells and impair the cilia functions. Asthma and COPD, then inherent lung diseases. Immunosuppression like AIDS, transplant patient or chemotherapy. So definitely they suppresses the immunity. Dementia, again more and more people will have the aspiration pneumonias. Diabetes, so itself is a secondary immunosuppressive syndrome, a defective neutrophil functions. CKD, so that is also the reduced humoral response, leukocyte chemotaxis, and the complement depletion. Chronic lung diseases, cold weather, very common pneumonias in the month of November and the December and the January. So the dry mucous membrane and the person to person spread, they common in the winter. Heart diseases, especially your heart failures or cardiomyopathies or alcoholic cardiomyopathy. So there will be the impaired lymphatics and alveolar macrophage functions. Edema predominates, promotes the bacterial growth. So these are all the different risk factors. As a physician, we see all these cases. So we know what about the viral infections, and we see a lot of the geriatric population, alcoholics, smokers, and known asthmatics and the COPDs, the people with immunosuppression, like post-transplants or already HIV or AIDS or chemos. Dementia is now common, very common in the society. Even at the age of 50 years or 60 years also, a lot of the people are getting the dementia. Now post-COVID sequelae. So again, there is a brain fog. It's a very common in some of the individuals with post-COVID. Diabetes is a very common in our society. CKD is also very common for the simple reason that more and more diabetes and hypertension, these two are the risk factors for the CKD. cold weather, cardiac problems, heart diseases. Even the heart failure is also very increased in the society because the most common cause of heart failure is ischemic heart disease. So no one is dying with ischemic heart disease nowadays because of the good interventional cardiologists. So we are doing the primary PTCS or streptokinase, etc. And we are making the IHD individuals to live for the long period, and finally they will have the cardiomyopathies or myocardial damage leads to the heart failure with your heart failure PEF or heart failure REF or heart failure mid-range rejection fraction. Risk factors in the patients requiring the hospitalizations. So older, unemployed, unmarried, common cold in the previous year, asthmatic, COPD, steroid therapy, bronchodilator usage, any chronic diseases, and more the smokers. Alcohol not related to the increased risk, but definitely the excess alcoholism will definitely lead to aspiration pneumonia. So this is the practical classification. CAP is community acquired pneumonia. HAP is a hospital acquired pneumonia. Again, there are two types: ventilator and healthcare associated, and aspiration pneumonias. Pneumonias in the immunocompromised patients. A word about the hospital acquired pneumonia. Pneumonia occurs more than 48 hours after the admission, which was not incubating at the time of the admission. Ventilator associated pneumonias more than 48 hours after the intubation, and the healthcare associated pneumonias. So this is a definition for the CAP, community acquired pneumonia. An acute infection of the pulmonary parenchyma associated with at least some symptoms of the acute infection. Presence of an acute infiltrate on a chest X-ray or auscultatory findings consistent with the pneumonias. In a patient not hospitalized or residing in a long-term care facility for more than 14 days before the onset of the symptoms. So this is the definition of your community acquired pneumonias. It can be defined both on the clinical as well as the radiological findings. In the absence of the chest X-ray, CAP is defined as symptoms of an acute lower respiratory tract illness, cough with or without expectoration, breathlessness, pleuritic chest pain for less than the 1 week. So think of the pneumonia, or at least one systemic feature, like the more the blood, more the temperature, with the chills, rigors, severe malaise. So definitely it's a lower respiratory tract infections, fever, chills and rigors. So mostly the pneumonia. New focal chest signs on the examination. So diminished breath sounds, or aortic bronch breath, or coarse crepitations, or fine crepitations. Okay, so these are all the features you can see on a signs in the examination of the chest. Bronchial breath sounds on the crackles, and no other explanation for the illness. So definitely think of community acquired pneumonia, even in the absence of the chest X-ray. Now the chest X-rays are available nook and corner of the place. So definitely we get on chest X-ray. Even the chest X-ray, now we are getting the CT chest also for the most of the cases. When a chest X-ray is available, CP is defined as symptoms and signs of NABO, that is the lower respiratory tract infections, like cough, some breathlessness, pleuritic chest pain, chills, rigors, loss of appetite, etc. With a new radiographic shadowing, for which there is no other explanation. So not due to the pulmonary edema or the infarction. The community acquired pneumonia, the common pathogens are usually caused by a single organism in community acquired pneumonias. Unlike your VAP and hospital acquired pneumonias, they are the multibacterial, whereas the community acquired pneumonia is usually a single organism. Streptococcus pneumonia is the most common cause. Isolation of the organism is in only 5 to 80% of the cases. Many culture negative cases are caused by the pneumococcus. Sputum culture is negative in about 50% of the patients with concurrent pneumococcal bacteremia. Majority of the cases of unknown etiology respond to the treatment with the penicillin caused by a variety of the bacteria, viruses, and the fungi. See, as I told you, the CAP is usually caused by the single organism. Pneumonia is the most common, and many culture negative cases are caused by the pneumococcus. It's very difficult to get the culture positive for the pneumococcal pneumonia, streptococcus pneumonia. The sputum culture is negative in about 50% of the patients with the concurrent pneumococcal bacteremia. Majority of the cases of the unknown etiology, they respond to the treatment with the penicillin. So just like with your pneumococcal pneumonias. And others caused by the viruses and fungi also. So the pneumococci are required for the aerosol inhalation, leading to the colonization of the nasopharynx. Colonization is present in 40 to 50% of the healthy adults and persists for about 4 to 6 weeks. Carriage is more common in the children and the smokers. Healthcare associated pneumonias. The pneumonia that occurs in a non-hospitalized patient with extensive healthcare contact, like our doctors, nurses, paramedics, etc. IV therapy, wound care, or IV chemotherapy within the prior 30 days. Residence in a nursing home or other long-term care facility. Hospitalization in an acute care hospital for 2 or more days within the prior 90 days. Attendance at a hospital or hemodialysis clinic within the prior 30 days. So these are healthcare associated pneumonias. Already I told you this pathogenesis. Microaspiration, inhalation, aspiration, bloodborne, hepatogenous spread. So these are the different organisms. In microaspiration from the nasopharynx, pneumonia is more common. Inhalation, pneumonia, tuberculosis, viruses, and legionella like atypical pneumonias. In the aspiration, anaerobes. In the bloodborne, staph endocarditis and septic emboli. So what are all the symptoms and the signs? The clinical presentation of the pneumonia varies depending on the causative agent like the bacteria, fungus, etc. and severity of the infection and host factors. There are some common symptoms and the signs. They include the cough, usually the productive, with a sputum that may be the purulent, yellow or the green, maybe the hemoptysis, blood tinged or the rusty. So most of the times if you ask the color of the sputum, mostly the yellow, green, rusty, blood tinged, these are very common answers we get it. So mostly it's the pneumonia. Fever usually accompanied by the chills and the rigors. Shortness of the breath is a very common. Chest pain, pleuritic chest pain is often present, especially the deep breathing or the coughing. And other symptoms, generalized symptoms like fatigue, headache, myalgia, nausea, vomiting, diarrhea, they are more common with the viral pneumonias. So general symptoms already I told you like fever, rigors, etc. And pulmonary symptoms also I told you, the cough, pleuritic chest pain or breathlessness. And rust colored sputum may be seen in patients with streptococcus pneumonia. Occasional patient may report the hemoptysis. Pleuritic chest pain, sometimes the pain referred to the shoulders or the anterior abdominal wall. Upper abdominal tenderness in the lower lobe pneumonia if there is associated hepatitis. Less typical presentations may be seen in very young and the elderly, and especially in the viral pneumonias, you will have the gastrointestinal side effects like nausea, vomiting, diarrhea. So these are all the typical presentations. Usually sudden in onset, that is the one important thing with the pneumonia, is not insidious pneumonias. So very sudden in onset, fever, sudden in onset, high grade fever, chills and rigors, associated with the cough, etc. Productive cough mostly the mucopurulent. There will be the tachypnea and the tachycardia, breathlessness, pleuritic chest pain, and breath sounds, crackles and the rails. And if you see the X-ray, there will be air bronchogram and the consolidation pictures. So this is the typical presentation of a community acquired pneumonias. See the main symptoms and signs: the systemic fever, chills, skin blueness, lungs, cough with the sputum, etc., muscular fatigue, central headache, loss of appetite, vascular hypotension, heart tachycardia, gastric nausea and vomiting and diarrheas, and maybe the arthralgias. So, as a physician, as a good physician, with seeing the pneumonias, so don't pertain only to the respiratory tract only. So sometimes some people may have the other symptomatology also, other system symptomatology also, along with the respiratory tract symptoms. So the atypical pneumonias are the gradual in onset, mostly afebrile. Once the febrile, anyone can diagnose that febrile and respiratory symptoms. So your thinking is mostly the pneumonias. But even in the afebrile stage, so you should think of the atypical pneumonias. Here it is not the mucopurulent sputum, but it's the dry cough, rales, uni or bilateral patchy infiltrates. WBC usually normal or slightly high, whereas the pneumonia, the WBC usually high, and sometimes that may be low also in the gram-negative sepsis. So there will be the sore throat, myalgias, fatigue, and the diarrhea. Here the common etiology: Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella, Mycobacteria, some viruses. So this is the atypical pneumonia. So as a physician, you should diagnose the atypical pneumonias in the absence of the fever, in the absence of the mucopurulent sputum, and in the absence of the more breathlessness. So the vague symptoms will be there, and should check X-ray also to be done. So definitely you can diagnose this atypical pneumonias. And the signs, there will be the tachypnea, respiratory rate will be more than 18, tachycardia, heart rate will be more than 100, temperature will be high, crackles at the rails, head and the auscultation of the affected lungs, the right lower lobe or the upper lobe, etc., mid lobe, etc., and the decreased breath sounds over that consolidated area, dullness to the percussion, again over the consolidation, egophony, head over the affected area, rub indicates the involvement of the pleura, so the rub will be heard only on the deep inspiration and will be reduced in the expiration. So the physical exam findings are often non-specific and may vary depending on the causative agent, location, and extent of the pneumonia. Okay, so these are the different signs. So tachypnea, tachycardia, fever, and auscultatory findings, percussion findings, palpatory findings, and the rub. The clinical presentation, the typical sudden onset of the symptoms, fever with the chills, productosputum, and chest pains. Consolidation signs depends on the percussion, dullness on the percussion. You will hear the bronchial breath sounds, not the vesicular breath sounds. Egophony, whispered pectoralogy, whispers are transmitted clearly. Pneumococcal pneumonia may present atypically, especially in the older areas where confusion or delirium may be an initial manifestation. So the confusion, delirium in the elderly individuals with your tachypnea, tachycardia, and light fever. So again, you think of pneumonias. In the atypical pneumonias, the presentation is a gradual in onset, not sudden in onset, afebrile, dry cough. So these are different organisms. Aspiration pneumonia is a mixed flora, mouth anaerobes, stomach contains the chemical pneumonitis and enterobacterium. So these are the aspiration pneumonia. So the mixed flora, both the respiratory as well as the gastrointestinal. So the clinical features of these different organisms. If you see, your favorite one is the Streptococcus pneumoniae, most common in the cap, most common in the winter, all age groups, particularly young to the middle age. So mostly of our physician practice. Rapid onset, high fever, pleuritic pain, herpes labialis, that is a very common association in the pneumonia cases, and rusty sputum. So the sputum is not mucus, it is a mucopurulent and rusty, and bacterium is more common in the women and patients with the diabetes and the COPD. Chlamydia pneumonia, the young to the middle aged, large-scale epidemics, often mild, self-limiting disease, headaches, and a longer duration of the symptoms before the hospital admission, usually diagnosed on the serology, that is a chlamydia pneumonia. Mycoplasma, children and young adults, common in the autumn. Epidemics occur every 3 to 4 years. Rare complications include hemolytic anemia, Stevens-Johnson syndrome, erythema nodosum, myocarditis, pericarditis, meningoencephalitis, and Guillain-Barré syndrome. Legionella pneumoniae, middle to the old age, recent foreign travel, local epidemics around the point source, that is the cooling law. A variety of the features are said to be more common, such as the headache, confusion, malaise, myalgia, high fever, and the diarrhea. So that is the Legionella pneumonia, atypical pneumonia. Laboratory results include hyponatremia. So there will be elevated SGPT and SGOT, hypoalbuminemia, and elevated creatine kinase. Chest X-ray appearances may be slow to the resolve. H. influenza, often underlying lung diseases like the COPD and the bronchiectasis. Staph aureus, coexistent debilitating illness and often preceded by the influenza. X-ray features multilobar shadowing, cavitation, pneumatoceles and the abscesses. Dissemination to the other organs may cause the osteomyelitis, endocarditis, or the brain abscesses. So mortality up to the 30%. So Staph aureus is very, very dangerous. So along with the pneumonias, so they involve the heart also, endocarditis, vegetations, etc. in the brain abscesses. So more of the emptogenic spread. Chlamydia psittaci, the contact with the birds, especially recently imported exotic birds, parrots, domestic dogs and the turkeys. They will be having the malaise, low-grade fever, hepatosplenomegaly. Q fever, Coxiella burnetii, a male, form or abattoir contact, chronic course, influenza-like illness, dry cough, high fever, conjunctivitis, hepatomegaly and endocarditis. That is a Q fever. Klebsiella, more in the males and alcoholics. Upper lobe involvement is the typical, and there will be the thrombocytopenia and leukopenia. So thrombocytopenia, leukopenia, upper lobes involvement, Klebsiella. Actinomyces israeli, the mouth commensal, cervicofacial, abdominal or pulmonary infections, empyema, chest wall sinuses, pus with the sulfur granules. So the more of the abscess formation, sinus formations, etc. So these are the different organisms causing the typical features like Staph pneumoniae, chlamydia, mycoplasma, legionella, H. influenza, Staph aureus, chlamydia psittaci, Q fever, Klebsiella, and actinomyces. So outpatient, inpatient, non-ICU, inpatient ICU. What are the common organisms? So in the outpatient, it is the Streptococcus pneumoniae, Mycoplasma pneumonia, H. influenza, chlamydia, and viruses. So they are very common in the outpatient pneumonias. Inpatient non-ICU, the wards, again the pneumonia, Mycoplasma pneumoniae, H. influenza, Legionella, aspiration pneumonias, and viruses. And some are very particular in the ICU setup. Here the Staph aureus, along with the pneumonia, Legionella pneumonia, gram-negative, and H. So in the inpatient or ICU pneumonias, they are having very high mortality because of the presence of the Staph aureus. Here you need to use a cephalosporins, very high grade, and a good amount at a regular dosages. Not 6th hourly, not 12th hourly or the once a day. So again, you have to give it as 8th hourly or the 6th hourly also. So this is a very important organisms as an outpatient, inpatient without ICU, inpatient in ICU. Streptococcus pneumonia, 20 to 60% of the CAP cases. H. influenza, 3 to 10% of the CAP cases. Legionella pneumonia, 1 to 5% of the adult pneumonias, or 2 to 8% of the community-acquired pneumonias. Klebsiella, Pseudomonas, E. coli, Staph aureus, about 3 to 5%. Atypical organisms like Mycoplasma pneumoniae, Legionella pneumoniae, they are up to 40% of the cases of the CAP. Pneumococcal infection is responsible to 50 to 70% of the CAPs. Influenza infection is one of the important predisposing factors to Streptococcus pneumonia and RS pneumonia. So these people will have the herpes labialis. Gram-negative organisms are very common of the nosocomial pneumonias. So the diagnosis, history and physical examination, definitely you can come to a reasonable diagnosis of the pneumonias. So the medical history, the healthcare provider will inquire about the patient's symptoms, their duration, any recent illnesses or exposures, travels, contact with the sick individuals, etc. Questions may also cover the vaccination history and underlying the health conditions that could predispose the patient to the pneumonia. Clinician will perform a physical examination focusing on the respiratory system, your inspectory findings, palpatory, percussion, auscultation, and also the examination of the other systems like splenomegaly or your endocarditis picture, etc. Auscultation of the lungs may reveal the abnormal sounds, crackling or the bubbling, which are indicative of the pneumonias. These are all the diagnostic tests. So chest X-ray, blood examination, sputum examination for your gram style or for your culture sensitivity, pulse oximetry to know whether the patient is in hypoxia or not, CT scan chest, so definitely it helps you a lot, whether peripheral disease or the central disease or honeycombing or upper lobes or lower lobes or any abscess formation or bronchiectasis or interstitial lung diseases or asthmatics or COPD. So a lot of information you get it on the CT scan. Arterial blood gas test in some cases, not in all patients. Pleurotic fluid culture. Suppose the patient is having a pneumonia, a pneumonic pneumonia, parapneumonic pneumonia, effusions. So definitely you should tap that and send it for the culture and sensitivity, ADA, etc. Bronchoscopy in some cases may be performed to directly visualize the airways and collect the samples for the further analysis. So the common investigations we often do is an X-ray, blood examination, sputum examination, CT chest, and sometimes pleural fluid culture. And some people they may need ABC and the bronchoscopy. So this is the diagnosis: the cough, difficulty in breathing, that's your breathlessness. Clinical signs, maybe tachypnea, chest and drawing, signs of the severe respiratory distress, hypoxia. In severity, the general danger signs, see the detection of the causes, host response, biomarkers, etc. WBC usually rise. So some people, the total count will be 18,000, 20,000, 30,000, etc. But the normal in the patient, the pneumonia caused by the atypical organisms need not be always elevated. Neutrophil leukocytosis favors a bacterial etiology. Here the neutrophils will be 80%, 90%, whereas the lymphocytes will be 5%, 10%. Very high or the low white cell count may be seen in the severe pneumonia. Sometimes need not be always the leukocytosis. Sometimes the leukopenia is also seen in pneumonia patients. Urea and electrolytes and the liver function test should be also checked, and sometimes in severe patients, so there may be the associated acute kidney injury, etc. CRP is typically elevated, like your ESR, so they are the inflammatory markers. So ESR and the CRP will be elevated. X-ray to update the radiological confirmation. So which lobe is involved, or both the lobes are involved, or extensive disease. Exclude other conditions that may mimic the pneumonias, like the pulmonary edema or cardiomegaly. To obtain a microbiological diagnosis. So sometimes when the upper lobes are involved, cavitary, so definitely a Cox etiology is noted. So with a chest X-ray, you can assess the microbiological diagnosis also in some cases. Definitely the severity of the pneumonia, identify the development of the complications like pleural effusions, etc. In lobar pneumonia, a homogeneous opacity localized to the affected lobe or the segment usually appears within the 12 to 18 hours from the onset of the illness. Radiological examination is also helpful if a complication such as parapneumonic infusion or intrapulmonary abscess formation like lung abscess or empyema is suspected. So chest X-ray demonstrates the infiltrate, establish the diagnosis, detect the presence of the complications such as the pleural effusion or the abscesses. See here the left lower lobe involvement. So right midlobe involvement. So these are laboratory investigations, routine lab investigations, CBC, VUC, electrolytes, sugar, liver enzymes, blood cultures, sputum cultures, simple gram stain, chest X-ray and CT chest, serological tests like pneumococcal antigen test, Legionella antigen, pulse oximetry, ABG, bronchoscopy in some cases. Sputum gram stain and the cultures, the yield of the sputum cultures varies from 34% to 86%, not 100%. Initial sputum gram stain and the culture or invasive respiratory samples appropriate should be obtained in all the hospitalized patients before you start the antibiotics. In the hospitalized patient, get a sputum test to be tested. Sputum quality should be exuded. So these are the different pictures of your sputum. PA and the lateral view establish the diagnosis, delineate the extent of the consolidation, indicate the presence of the underlying disorders, identify the complications like pleural effusions, multilobular abscess, lung abscess, prognosticate the disease. So chest X-ray performed early in the course of the disease could be the negative. That is the most important take-home point. So on the day of the pneumonia, maybe on the second or the third day of the pneumonia, you may not see the abnormalities in the chest X-ray. So chest X-ray could be the normal, like your ECG in early myocardial infarction. So in the first few hours of the myocardial infarction, so the ECG may be the normal, even the echo may be the normal also. So the serial ECGs are very, very important. So when you have a high index of suspicion, so admit the patient and get the test to be done again. So in the chest X-ray, mostly the 5 patterns will be seen. A lobar pneumonia, so that is the Streptococcus pneumonia. Patchy pattern, mostly the virals or atypical pneumonia like Mycoplasma, Legionella, Chlamydia. Interstitial pneumonias in influenza, cytomegalovirus or biliary tuberculosis. Abscesses are very common in Staph aureus and anaerobes. And a nodular in the fungal infections, histoplasmosis, coccidiomycosis and cryptococcus. Bulging fissure sign of the Klebsiella. Bulging fissure sign of the Klebsiella pneumoniae, pleural effusion, Streptococcus, anaerobis and Klebsiella. So these 5 patterns is important. So as a physician, whenever you see an X-ray in a pneumonia patient, so think of the lobar pneumonia. Is it patchy pattern? Is it interstitial pneumonia? Are there any lung abscesses or any nodular pneumonia? So because the organisms are different, is these things. Again, I repeat, in a lobar pneumonia, usually caused by the Streptococcus pneumonia. The patchy pattern, either viral pneumonia or atypical pneumonia. Like atypical means Mycoplasma, Legionella or Chlamydia. In interstitial pneumonias, mostly the viral or the biliary tuberculosis. So influenza, cytomegalovirus, etc. Lung abscesses, so the most dangerous organisms, Staph aureus and some anaerobes. Nodular, mostly the fungal infections. So again, more common in the diabetic individuals, alcoholic individuals, or in HIV positive individuals. So the fungal pneumonias. Here, the histoplasmosis, coccidiomycosis, cryptococcus. So here it is the nodular pneumonia. So as a physician, so you should identify the pneumonias as the lobar or patchy or interstitial, abscess or nodular. See the mycoplasma, the pseudomonas. The pseudomonas is very dangerous. Okay. Mycoplasma, right upper lobe involvement, right lobe involvement here. See the aspiration pneumonia, abscess formation. That's one, lung abscess, the aspiration. Okay. Here the pneumocystis. So the viral pneumonias. So the right lobe, right lower lobe. So here the before the treatment, after 2 weeks of the treatment. Air bronchogram, lobar pneumonia. So whenever you see, read a chest X-ray, these 10 points are very important. Anatomy of the chest X-ray. So see the trachea, that is a pulled or the pushed or in the center line. See the hyla, when a hilar adenopathy, and then the lungs. So in the upper lobes are the mid lobe and lower lobe on the right side, upper and the lower lobes on the left side. Diaphragm, so the right side of the diaphragm, the left side of the diaphragm. Heart, so usually 50% of your area, if it is more than the 50%, so think of any cardiomegalis, right heart, right heart border, left heart border, etc. Aortic knuckle, so especially very common in elderly individuals. Ribs, sometimes coarctation of the aorta, or maybe the secondaries, or maybe the fractures. Scapula, spine, and the clavicle. So these are the 10 basic points we are supposed to see in a chest X-ray. So the rotation, these are very important. See the domes of the diaphragms, costophrenic angles to rule out any pleural effusions. So just PA view and the lateral view. So the different pneumonias and the normals. See the lobar consolidation, diffuse consolidation, multifocal, atelectasis, right upper lobe atelectasis, the center one. Fine reticular interstitials, coarse and fine nodular, solitary pulmonary nodule, and multiple secondaries. So the different pictures. Normal, mildly abnormal in the upper lobes. Here both the lobes are involved here, and severely all the lungs are involved here. See the presence of the fluid, lower lobe involvement. See the infiltration, first one, then the atelectasis, cardiomegaly, maybe the pulmonary edema, effusions, mass lesions, nodules, pneumonic patch, sometimes the pneumothorax, associated pneumothorax. See the first one is the normal picture, the center one is the pneumonia in the right upper lobe, in the viral pneumonias. Right middle lobe consolidation. So clinical diagnosis, the suggestive signs and the symptoms. Already told you what are all the symptoms and the signs. And chest X-ray findings, we have seen some X-ray findings here. Microbiological testing is also equally important. So the gram stain and the cultures. These are all the common organisms. Common positive, gram positive, diplococci. They are the pairs and the chains. Gram positive clusters, the Staphylococcus pneumoniae. Gram negatives, Klebsiella pneumoniae, rods, etc. Organisms not visible on the gram stain. So atypical pneumonias. A full range of the microbiological tests should be performed on the patient with severe care. Identification of the Legionella pneumonia has important public health implications. People who do not respond to the initial therapy, microbiological investigation may lead to the appropriate modification of the therapy. So definitely our cultural sensitivity will tell us so which antibiotic you are supposed to use it, whether they are sensitive or the resistant. It provides a useful epidemiological information also. So this is the gas exchange. All patients, severe community acquired pneumonias, selected patients. In all patients, sputum direct smear by gram stain and Gill-Nelson stains, culture and antimicrobial sensitivity testing. Blood culture frequently positive on the pneumococcal pneumonia. Serologies, these are all very important for all the population. So the physical examination is important, blood counts are important, sputum examination is important, urine tests, PCR in some cases, CT scan in most of all the cases are needed to know the complete picture of the pneumonias. So one word about the viral pneumonias, the COVID-19, the SARS-CoV-2 virus, we discussed extensively on the COVID 2 weeks ago. It can be severe and lead to the respiratory failure. Influenza pneumonia caused by the influenza virus. So don't think that is very common and very simple. Sometimes it could be very serious and the fatal also, H1N1, especially in those with the pre-existing heart and the lung diseases. Respiratory syncytial virus, the most common cause in the young children. Fungal pneumonia is also very common in the subset of diabetics and HIVs. Pneumocystis pneumonia, a serious infection caused by this fungus occurring in the immunocompromised individuals. Valley fever caused by the fungus coccidiomycosis. Histoplasmosis caused by the fungus histoplasma. So these are the other types. Here you can appreciate here the segmental pneumonias. Superior lobe, middle lobe, lower lobe, multi-lobe, unilateral pneumonia, and the bilateral pneumonia. What about the DD of the pneumonias? See, not all these symptoms and signs are because of the pneumonia. So as a good physician, it is very, very important to know the DDs of any disease. Pulmonary infarction, just like they present like the pneumonias, or pulmonary or pleural tuberculosis, pulmonary edema, pulmonary eosinophilia, sometimes malignancy, especially the bronchoalveolar cell carcinoma, and rare disorders like cryptogenic organism pneumonia, bronchiolitis obliterans. So out of them, pulmonary infarctions are common, pulmonary tuberculosis are very common, pulmonary edema is very common, pulmonary eosinophilia is common, and nowadays even the malignancy of the lung carcinoma are also very common. So these are the 5 common DDs for our pneumonias. The same thing here. So coming to the treatment, why do we need to treat? Because it is potentially fatal disease. So you see, we have seen some cases like Staph aureus, etc. So definitely high morbidity and the mortality. Eradicate the causative organism from the site and reverse the inflammatory process. Prevent the complications and prevent the mortality. Prompt initiation of the antibiotic therapy is the most important step. You don't wait till your culture and sensitivity reports or your bacteriological reports. So start empirical antibiotic in all the pneumonia cases. Pathogen-directed antimicrobial therapy whenever possible. A rational use of the microbiology laboratory, and a decision to hospitalize based on the prognostic criteria, whether it's an outpatient or an inpatient. Decide whether as an inpatient, again decide whether the patient should be kept in the ICU or non-ICU. So criteria for the risk stratification. The fellow is having the confusion. When the urea is the more, when there is a tachypnea, when there is a hypotension. So definitely on the age more than the 65. So there is a cut 65. C stands for confusion, U urea, R respiratory rate, and B is the blood pressure, and 65 is the age more than the 65. So definitely these people need admission in the ICUs. So major criteria and the minor criteria for ICU admissions: invasive mechanical ventilation, septic shock with the need for the vasopressors, so in the ICU management, you have the pathogen directed treatment like amoxicillin, clavulanic acid plus the macrolides, third generation or fourth generation cephalosporins, fluoroquinolines, aminoglycosides like your amikacin, carbapenems, vancomycin, teicoplanin, metronidazole or clindamycin. These are all the useful drugs we often use in the ICU setup. So initially you may start with the cephalosporin plus macrolide plus aminoglycoside, and slowly after the reports you can change over to the carbapenems or your vancomycins, etc. So these are the criteria for the clinical stability: when the temperature is coming down to the normal, when the heart rate is the normal, when the respiratory rate is the normal, when the BP is maintaining the normal. So that is the best time to change over to the ward or to the outpatient. So generally 7 to 10 days of the antibiotics are sufficient. So don't use beyond the 15 days or the 20 days or 25 days in the pneumonia. Usually they require about 7 to 10 days of the antibiotic course. Once the stability criteria are met, patient can be switched to the oral antibiotics. Hospital-acquired pneumonia is an inflammatory condition of the lung parenchyma caused by the infectious agents neither present nor incubating at the time of the hospital admission. Defined as a pneumonia developing 48 hours after the admission to the hospital is hospital-acquired. Early onset and the late onset. Early onset defined as the pneumonia occurring within the first 4 days of hospitalization. Late onset day 5 or the thereafter. Burden is the second most common nosocomial infection, hospital-acquired pneumonia. It accounts for about 25% of all ICU infections and more than 50% of the entire antibiotic prescriptions. Mortality rate 30 to 70%. The risk of HAP and VAP is highest early in the course of the hospital stay. See, most of the VIPs in the AIMS and other prestigious hospitals, they die of pneumonias. The day of severe sepsis and sepsis related multi-organ failures. So that is the reason the hospital acquired pneumonias is a very important. So this is how they get the infections: the nasogastric tube, endotracheal tubes, through your hands. Okay. These are the common organisms: E. coli, Klebsiella pneumoniae, Acinetobacter, Staph aureus are more common in the diabetics, head trauma, and ICU admitted patients. So the differential diagnosis for your hospital acquired pneumonias: ARDS, heart failure, pulmonary embolism, especially the people on prolonged stay, fluid overload, maybe hydrogenic, pulmonary hemorrhage. So the basic principles: start the antibiotics as early as possible. The exact choice of the antibiotic to be started is based on the local availability, antibiotic resistance patterns, preferred routes of the delivery, and other complicating factors on the cost. Initial combination therapy should be converted to the appropriate monotherapy once the culture reports are available. The strategy for de-escalation of the antibiotics is strongly recommended. Among the patients with suspected VAP, in whom an alternative cause for the pulmonary infiltrates is identified, it is recommended that antibiotics should be stopped. If cultures are sent after initiation of the antibiotics and there is a clinical improvement with the subclinical cultures being sterile, antibiotics should be continued for 7 days followed by the assessment. Empirical antifungal therapy on day 3 should not be used as a routine in all patients if cultures are sterile and there is clinical worsening. Supportive care is very important, like controlling the fever with antibiotics. Staying hydrated is very important. Hydration is very important. Drinking plenty of the fluids. Rest. Using a humidifier, taking steamy showers to ease the breathing. Avoid the smoke exposure. Empiric outpatient management in the previously healthy patient. If the no comorbidities, no recent antibiotic usage, and a low rate of the resistance, like our outpatient in the outpatient department, so you can use the azithromycin, or clarithromycin, or the doxycycline. If the comorbidities are there, a recent antibiotic usage and high rate of the resistance, definitely respiratory fluoroquinolones like levofloxacin, moxifloxacin, they are the preferable. A combination therapy, a beta-lactam and a macrolide like amoxicillin, clavulanic acid or ceftriaxone. Here is the treatment, the pathogens, a gram-positive cocci, use the penicillin derivatives about the 10 days. In a gram-negative, aminoglycosides or the cephalosporins about 10 days. So respiratory syncytial virus, don't use any antibiotics. MRSA is a very important. Use the vancomycin and the linezolid. Pseudomonas, aminoglycosides and beta-lactam. So these are the important drugs to be used in our population. How doctors choose the antibiotic prescriptions for the bacterial pneumonias? So depending on the age, health history like comorbidities, specific infections, previous experience with the antibiotics, and antibiotic sensitivity of the bacteria. Treatment of the pneumonias, vaccination is very important. Medication, proper medication, take the antibiotics for a full course, not 3 days or the 4 days or the 5 days. So maybe 7 to 10 days. So the cover your mouth, have proper rest, 7 hours sleep, and good food. So there are the different antibiotics. Most common cause, risk factors, splenectomy for streptococcus pneumoniae, asplenia, sickle cell disease, hematological diseases, smoking, asthmatics and COPD, HIV. So they are all the risk factors for the pneumonias. So you have the two types of the vaccines here. One is the pneumococcal conjugate vaccine and the pneumococcal polysaccharide vaccine. So conjugate vaccine is a vaccine used to protect the infants from the young children. There are 7 serotypes of the streptococcus. But as an adults, we use the polysaccharide vaccine. It contains 23 serotypes of the streptococcus. So the PPSV, polysaccharide vaccine, is recommended for those over the age of the 65 years. So remember these associations. Asplenia, so streptococcus pneumoniae and H. influenza. In alcoholism, streptococcus pneumoniae, anaerobes, Klebsiella, COPD and the smoking, H. influenza, Pseudomonas, Legionella, streptococcus pneumoniae, Moraxella, Chlamydia. Aspiration pneumonias, Klebsiella, E. coli and anaerobes. So accordingly you can choose the antibiotics. HIV, so streptococcus pneumoniae, H. influenza, cox, fungal, atypical, recent hotel and cruise ship, Legionella, structural lung disease, bronchiectasis. So now presents with the pneumonia, so Pseudomonas, ICU and ventilation, so Pseudomonas and Acinetobacter. Antiviral, we use the oseltamivir, Tamiflu, 75 milligrams. So these are all the complications of the pneumonia. So bacteremia, septicemia, sepsis, respiratory failure, circulatory failure, pleural effusions, the parapneumonic effusions, empyema, abscesses. So these are the complications of the pneumonias. So respiratory failure, sepsis, bacteremia, pleural effusion, abscess, AKI, heart complications, pneumatocyl formation, chronic lung diseases. Prevention vaccines, already I told you. Hygiene, lifestyle choices, especially quit smoking, manage the chronic conditions, healthy living, environmental awareness is very, very important. So get the vaccine, get the influenza shot, pneumococcal shot, influenza shot, good hygiene, no smoking, making good healthy lifestyle choices. So the chapter you are learning today is going to save someone's life tomorrow. Pay attention. The greatest reward of medicine is not the title. It's the difference you make in someone's life.